able to do then is mask a symptom without making a significant positive effect on the way the foot is functioning. We had to do this in the early days because Mert was making orthotics out of Rohador, a very hard, unforgiving surface. I had a meeting of all the great biomechanists in Southern California. We brought Tom Scarlato down. And at the end, they turned to Tom and said, "Why didn't you do this back in the 60s? He said, "We didn't have the materials. The materials, the thermoplastics that we have today, didn't exist back in the 60s. So he chose Rohador. Because it's such a hard, unforgiving plastic, what happens? You fill in the arch to reduce that impact. So what do you end up with when you fill in the arch? You end up with a low, flat, smooth, invented generic shape. What do I mean invented? I mean you have just divorced the shape of the foot from the shape of the orthotic. The two now have no relationship to each other than size. Who determines the shape of your orthotic? The guy who's filling in the arch with plaster. That's how the shape of your orthotic is determined. Well, how do you then eke out some function out of a low, flat, smooth, invented generic shape? You got to look at the history of podiatry. Podiatry started as a 3-month course. M.J. Louis in 1912 started a 3-month course, and what they basically did was trimmed corns and calluses to prevent amputations, primarily in diabetics. And also, if you had a painful lesion right here, they made a U-shaped pad to take the tissue stress off this area and move it around the outside. What we were in essence doing was herding the tissue stresses around the bottom of the foot, like herding horses. So we ended up with the most incredible collection of pads. We had scaphoid pads and met pads and dancers pads and neuroma pads and cuboid pads and tilts and skives and flanges and grooves, and we had all of these things that I call the bag of tricks. And biomechanics, to a great extent, when I was taking it, was a bag of tricks. Who had the biggest bag of tricks, was the biggest guru in biomechanics? And today we've actually classified. There are companies that have said, well, if you have this pathology, you use this bag of tricks, this pathology, this bag of tricks. Now, most of you are too young to know who carried a bag of tricks. Which cartoon character was famous for carrying a bag of tricks? You guessed it. I call this the Felix the Cat approach to foot biomechanics. It's the bag of tricks. Now I'm going to show you what mass position biomechanics, how it differs. The first thing to note is what mass position means. What I'm trying to achieve by mass position is I want to capture the maximal amount of arch that a person can tolerate at mid-stance, that puts them in adequate supination of the foot to stabilize the subtalar joint in the sagittal plane for propulsion. The maximal arch supination stabilization position. That position is in the functional zone. What do I mean? It's in enough supination that the anterior facet is near level and the talus can effortlessly internally and externally rotate to lock and unlock these two bones in the sagittal plane. Mid-stance is the critical point, because at mid-stance a decision is made. At mid-stance you either have a foot, by the way, at mid-stance is critical because body weight is passing over the foot. Your center of gravity is passing the heel. You're about to go into heel lift. You either have a foot that's well supported, that's adequately resupinated at mid-stance to give you a propulsive lever, and you indeed have a propulsive gait. So if you have a foot that's adequately resupinated at mid-stance, you can efficiently propel forward. Or you end up with a foot that as it hits the ground, rolls in and collapses in the midfoot, and at mid-stance, you have a fairly collapsed arch and gives you a mid-stance that's collapsed and unlocked in the midfoot giving you what we call an apropulsive gait. What do I mean apropulsive and propulsive? They both propel you forward. What I mean is, it's the amount of efficiency in propulsion. If you have a propulsive gait, you're propelling efficiently. If you have an apropulsive gait, it takes an enormous amount of extra force to propel forward. That extra force becomes the deforming forces of the foot, ankle, knee, hip, and lower back. Let's look at some sample diagnoses. And I'm going to start with plantar fasciitis. Plantar fascia, one of the longest and strongest ligaments in the body, runs from the tuberosities of the heel to the phalanges. How can you tell it goes to the phalanges and not the metatarsals? Pull back on the toes, it pops out. That's called the windlass effect. Windlass is part of a sailboat. When there was no wind, they would throw the anchor and reel it back in. Somebody thought pulling the toes back was like reeling an anchor in. Let's take a look at some interesting physics here. The axis of motion of the first metatarsal is up and down. It's at the base of the metatarsal. Let's look at the pull of the plantar fascia. We have an axis, we have a force being applied. What's the purpose, firstly, of the plantar fascia? That after heel lift, it will dorsiflex the toes, induce the windlass effect, which will supinate the foot. It's a supinator post-heel lift, right? So let's take a look at it. Firstly, it's interesting to note that the force of the plantar fascia changes directions because of the sesamoids. The sesamoid redirects the force. What happens? Attaches to the sesamoid, the anterior sesamoidal ligament attaches to the base of the proximal phalanx. The phalanx cups the head of the metatarsal and causes the fascia to pull primarily, not totally, but primarily in a horizontal direction. Now you've got a force in a horizontal direction and an axis. Well, let's take a look and see what happens. When you have a force and an axis, let's put the force in. You can measure a distance, a perpendicular distance from force to axis. When you're supinated, that distance is huge. When you're pronated, it's quite small. How much does that change the stress on the plantar fascia? Simple trigonometry. When you go from 30 degrees of inclination angle to 15, you increase the force buildup in the plantar fascia by 253%. That's huge. In fact, let's take it to its logical end conclusion. If the fascia was parallel to the first metatarsal, what would happen? It would become nothing but an isometric stabilizer of the base of the proximal phalanx. It would, in essence, take an infinite force for the plantar fascia to do its job. But as you increase the angle, you increase the lever arm and make it easier for the fascia to do its job. The fascia adapts in its thickness to the stresses that are placed upon it. So what happens? We see on ultrasound, after a person has had plantar fasciitis, the fascia thickens back up, thickens up to adapt to the extra force. So what happens in real life? Patient, for one reason or another, their arch drops. The amount of force buildup in the plantar fascia increases. The plantar fascia has adapted in its thickness to apply the right amount of force, to resist the right amount of force. Now it drops, the thickness isn't there, the fascia rips. Tiny tears in the fascia end up being what we call plantar fasciitis. And it begins to tear also away from the heel bone, pulling the periosteum away from the heel, creating a late artifact on X-ray we call heel spur, which is only an artifact. So how would you fix plantar fasciitis? Increase the lever arm of the plantar fascial force by supinating the posture of the foot, by raising the medial longitudinal arch. Hallux abductovalgus, bunion deformity. Coming over an unlocked foot, the first metatarsal is free to move on its axis. So your body weight comes over an overpronated foot, you've unlocked the foot, the first metatarsal now reacts or moves due to the ground reaction force on its axis. Why doesn't the first metatarsal follow it like the peace sign? Why don't we have the victory sign? Because of the adductor hallucis pulls the hallux laterally.